is patent ductus arteriosus. Along with this, guys, you need to understand how prostaglandins work, and therefore how what an antiprostaglandin drug work. Okay, that's all the hint I'm going to give you there. But patent ductus arteriosus, we have something that's not going to close after birth like it should, and you can look at the picture and see what physiologically is going to happen to blood. Right? During normal fetal circulation, that's one thing, but post-birth, this could potentially cause all kinds of issues, especially with pulmonary flow, couldn't it? Y'all see from the picture there? So for patent ductus arteriosus, I would focus on, first of all, what effect is this having on the heart? And she does a really good job explaining that to you here. Okay? It talks about what would normally cause it to close, which is important, prostaglandins. And when we don't have that, okay, it talks about what would start a prostaglandin type response anyway. That's about all I'm going to tell you about that. What drug is an antiprostaglandin? And that tells you then what would be used for treatment, okay? There's your symptoms. We talked about a pulse pressure, didn't we? Remember, 25% is the minimum. Bounding pulses, we talked about that increased stroke volume contribute to, and decreasing SVR contribute to bounding pulses, okay? You can see where if we have a decreased flow out of the aorta, instead it's going to cause a lower blood pressure, right? If what comes out of the ventricle is diminished, then your blood pressure is going to be lower. Don't worry about what kind of murmur. Here's your treatment. Okay? Look at there, antiprostaglandins. Again, if you don't understand how prostaglandins work, you're not going to understand how this drug is going to work. And she does explain that very detailed in here, okay? So there's one of the disorders I told you to make sure you're very confident with. There's surgical things we can do as well. She's got a lot of cute pictures in here. Atrial septal defect, ventricular septal defect. I said no, both of these. And again, if you look at the picture, it can show you how is this going to affect blood flow. Because that's what we're looking at. And how do we treat it? What would be the symptoms associated with this? There we go. When you look at where it's located, it makes sense then when you see your symptoms, okay? So, that was one I wanted you to focus on. Atrial septal defect, ventricular septal defect, surgical, non-surgical. Ooh, look at there, endocarditis. Valvular action. So we got the valves that are involved. Remember that when you have anything, you have something that can alter the function of the valves, you can potentially have endocarditis. We'll talk about what that is. Look at that little closure device. How tiny it is. That's a dime, y'all. It's a picture of a dime. Look at the little closure device. It kind of sits there and closes the hole. I think it's pretty cute. All right, ventricular septal defect, we just have a different place instead of between the atria, we have between the ventricles. So, she goes through. So far we have patent ductus arteriosus, atrial septal defect, ventricular septal defect. She talks about what we're going to do to fix it. So, again, you have nursing process here. What would I expect to find on assessment? What's wrong with blood flow? I want blood flow going the right way. That's my goal. Increasing cardiac output or decreasing pulmonary flow, whichever it may be. And these are my treatments. And then the last biggie that I want you to look at. There's some closure devices. It's a piece of cloth, the actual little piece of cloth. Let's see. Coarctation of the aorta is one, but I won't spend a lot of time on that. If you look at the picture, it tells you what's going to happen, doesn't it? You have a kink in your aorta. What is that going to do to blood flow? Okay, so it can back up, first of all, right? If it can't get past the kink area, what's it going to do to what's coming out to the body? Reduce it. There you go. Okay, so, but this is the one I wanted to show you the most right here. Coarctation. We get to tetralogy. Don't worry about aortic stenosis. We're going to do that in adults. Don't worry about valvular disorders because they're going to be the same, pediatric or adult. Doesn't matter. This is what I want you to look at. The same thing, same type of replacements. Nothing's changed there. Don't worry about pulmonary stenosis. I'm not testing you on that. Okay, here we go. For tetralogy of Fallot, there are 4 things wrong. That's where tetra comes from. It means 4. There are 4 things wrong with this baby's heart. What are they? That's your job. What are the 4 things wrong with this baby's heart? That's why it's called tetralogy of Fallot. Fallot's the person that discovered it. 4 things wrong with this little munchkin's heart. I would be very competent at identifying what those 4 things are, and then what does the baby exhibit? What are my signs and symptoms? These hypercyanotic spells, or what they call TET spells for tetralogy, are very distinctive of this disorder. Very classic. So there's a picture right there. There's a TET episode, a hypercyanotic episode. Can y'all see that? So how do we treat that? Anybody know? Anybody read this already? How do we treat it? Knee chest. Good job. Woo. Knee chest. Okay? Treatment. Squat. Knee chest. It's interesting how children intrinsically know. You'll see the child squat, the toddler. But as a parent, you know that that's what we need to do. If it's a baby, obviously you're going to put the knees or arms towards the chest, okay? Those are the big ones I want you to focus on for this. Fair enough? Mm-hmm. Okay. That's as fair as I can be. Now, let's talk about study group. So we've got class time built in, so everybody can be here for study group. So what questions do you have? Huh? You guys remember, I sit here and say, remember, don't memorize. Okay. Duh. I do want you to memorize that I'm telling you not to memorize. I don't want you to memorize, because memory is going to fail you. I always tease my son, he doesn't know what he had for lunch yesterday. Memory's not his forte. But he remembers things that are important. As he considers it, he goes, that's in the category of not important. And he goes, I got too much important stuff to keep up with. Okay, I got you. And yet you have to have knowledge. So knowledge does require a certain degree of memorization, like normal potassium level, right? Okay. As you go through this, you guys, I'm telling you that if you really, ooh, that looks good. Celeste, what you got?
Oatmeal.
Ooh, squirrel. That looks good. It really does. I like oatmeal too. Is that like an instant oatmeal?
It is. It's downstairs. I just put too much water.
Like we have it here?
Yes, ma'am.
What you don't know, you learn every day. I might need to go cruise that. Okay. Lord, where was I at?
Don't memorize.
Yeah, don't memorize. Okay, so if you understand, I'm going to tell you really truthfully, if you really, really understand normal cardiac function, you're going to be able to pick out abnormal, and you're going to be able to know what to do about it. If I know that I have a heart muscle that has a very weak left ventricle, then I know what complication is going to occur because I understand there's higher pressure in the aorta. Okay? And if that ventricle's weak, it's not going to be able to overcome that higher pressure in the aorta when it contracts. So what's it going to do instead? Take the path of least resistance, which is the atria and the pulmonary bed. But then that also makes sense as to what pharmacology we would use to treat that, doesn't it? If I've got increasing volume going backwards, I need to do something about the volume. If I've got a contractile issue, I need to do something about the contractility. If I have a high degree of resistance in the aorta, then or through systemic circulation, then I need to do something about afterload. Right? It really truly makes sense if you think about it, but you have to understand normal pathophysiology, or it's not going to make sense. And you're going to try to memorize it, and it's going to confuse you, and then you're going to get that test question and go, oh, I don't remember. And that's what happens. When I tell you that you really need to know what preload and afterload, what are we talking about when we say preload and afterload? That's one of your keys to understanding the questions on this test. That's really important. You may want to look at some YouTube videos. You may need to get some additional resources, whatever you have to do to make sure you understand what preload and afterload are referring to. Okay? If a patient has adequate cardiac output, On a head-to-toe assessment, beginning with the head, what am I going to find on assessment for a patient with adequate cardiac output? Beginning with the head. Say it, Josh.
Just normal color tone.
Normal color and tone, what else, Jay? What about their mentation?
Well, I would say, yeah, to orientate, times three.
They're oriented, right? If a person has adequate cardiac output, then the brain is going to be perfused. And therefore, I would expect a patient who's an oriented person, time, place, and alert is the big key, right? Because orientation refers to a neurological problem, whereas alertness refers to a perfusion condition, correct? We have two things we've assessed. Alertness does not imply orientation. Orientation does not imply alertness, okay? So I would expect a patient that's alert. What else would I find? Josh identified overall color. Mucous membranes are what? Pink, okay? The color specifically, not necessarily whether or not it's moist, right? Moist implies what? Adequate hydration, okay? Perfusion is gonna be my color. What about my cat refill? What's it gonna be with normal cardiac output? Less than 3 seconds. What about my urine output? My normal, should be typical characteristics of what we consider normal: pale urine, adequate output, right? Peripheral pulse quality should be what? 2+, right? I should have a good adequate blood pressure. Those are my findings that would tell me as a nurse, I'm reasonably comfortable that we have good cardiac output. Whereas findings of abnormal or low cardiac output would be what? Beginning with mentation. Most likely start having a patient that's not as responsive to me anymore. Remember, not necessarily confusion, yes, but confusion can be baseline with a patient who's adequately perfused.
So someone who's taking a little bit longer to answer questions.
Right, maybe someone who's becoming a little less responsive to me. Because what's the brain gonna do when it doesn't have adequate perfusion? It's gonna quit functioning. So if a patient becomes lethargic, drowsy, less responsive to me, like, what's going on there? What's going to my peripheral pulse quality? It's gonna be low. What about my urine output? It's gonna go down. My extremity color is gonna turn what? Pale, by comparison to the patient's baseline skin color. Can I discern pale among a patient with a dark complexion? Yes. You will see a color change. Okay? So look at that patient. Do I see change in their normal tone? What about temperature? Cool, okay? So think to yourself, what tells me I've got adequate cardiac output? What tells me I don't? Okay? Go through the nursing process with these multiple different disorders. I promise it will help. So back to hemodynamics. Remember, with hemodynamics, you absolutely must know your normal values. A blood pressure does no one any good if the person assessing it doesn't know what normal is, right? It's just a number. So what are those normal values? Now that we know the values, what information is this going to provide you in regards to your patient's care? So let's make a little example. You have a patient with 1,400 dynes per second per centimeter, -5, whatever it is. Seconds to -5. Is 1,400 normal, elevated, or low? Say it again. The normal is what? 8 to 1,200. Very good, Josh. So 1,400 is elevated. Okay, so you've got an elevated systemic vascular resistance. What drug classification would lower that? Broad category. Vasodilators. So after I've given a vasodilator, what should I expect to see on my monitor in regards to my SVR? It should come down. That's exactly right. We're not doing anything different with this module than we do with any patient we've ever taken care of before. If I have a patient who has a fever and I've given them an antipyretic, well, it should come down. But I had to know what the normal temperature was to start with, so that I would know there was an aberration from normal, right? Okay, that's all we're doing. Your Form Made Easy module is a really good, okay, let me take a moment for HI for a second. You guys, I've given some of you guys a little heads up, and I've taken some grades back out. I will give them back, I promise you, but you have to use 203 documents. You cannot submit to me a 202 document. Don't use 202's critical no points, don't use their rubrics in clinical. We have 203 documents, and that's what's gonna be uploaded, okay? Look at what it's asking you. This is the only module that I'm going to give you those opportunities to fix things before the due date. Y'all, that's, you know how much work that is? Take the number of students in here times the number of assignments that have to be done, and one person critiquing that. It's a lot. I'm not gonna do it after module A. Okay, I'm not. I don't have to in the first place. After module A, what's in there is good, that's what gets graded. And if you forfeit your points, you forfeit your points. I don't know what else to tell you. Look at what's required of you, make sure that that's submitted and it's submitted correctly. I'm not doing it anymore. I don't have time, guys, okay? I don't. So, take a moment, go back and look at your stuff. Did you submit what you're supposed to submit? Is it reflecting everything that was required of you on the rubric? It's very, very clear. I uploaded an example of the certificate of completion for the skills module under the, not the Dropbox page, because I would have had to do it 11 times, and I'm not going to do it. But on the actual, where it has the rubrics, it's under the skills module rubric. There's an example of what a certificate of completion looks like. You can secure those in your ATI account, okay? Get those certificates. Just trying to be as, again, I take pride in being fair. I also want to give you the chance to that first time, okay, what's expired, but that's it now, okay, y'all? So y'all take ownership of your own outcomes, submit what you are supposed to. I won't be giving it, starting with module D if I'm not doing it, okay? Okay. That was my squirrel moment. But going to ATI, Farm Made Easy, the CV module, does a really good job going through a lot of different neat drugs that you've probably not really delved into throughout the curriculum to this point, right? There's some pretty neat things you learned in there about those cardiovascular drugs and how they work. Remember, that is testable content, okay? You've been given the assignment. It's there for a reason to help you learn something. Nobody's sitting there looking for the one little sentence in the one little paragraph that would be arbitrary that a student might not recall. That's useless and pointless, okay? But conceptual understanding of it, we do expect you to have. So look through that. Do you really understand how those drugs work? What patient education do you need to perform? That's really important, isn't it? Be on your A game, be proactive and making sure you're taking those and taking notes. As I'm going through these things as a student, I would take notes. If there's a drug I'm like, I have never heard of this before, that makes a great critical point. Remember, we'll give you a lot of autonomy on your critical points. You figure out what it is that you didn't understand. I hate endocrine, y'all. I'm just gonna tell you right now. Oh, and to this day, it's like, oh, okay, let me go look it up, because I despise it. Let me go look it up again. You know, go back and look, oh yeah, that's how that works. But those are the things I would make my critical points on, because I know that's an area, because I dislike it so much. That's something I made myself work hard on. I still don't like it, but I work on it, okay? So look at those things that you know you didn't understand. That's your critical point. We give you the autonomy so that not everybody has to have the same one, okay? And then when you do those critical points, if you think you're getting away with 3 sentences in one box, the answer is no, you're not. But again, are you hurting me? It hurts my feelings. I don't like when I see students that don't care anymore about their outcomes to do that. I don't know what to say. I'm trying to do my best to help you, but you're not trying to do your best to help you. I don't know what else to say. So look at your critical points. Are they meaningful? Did they reflect that you learned something you didn't know before? Have you put them in plain language so that you do understand it? That's what they're for. They're to help you. And they're tools that you can use as you prepare for NCLEX. Okay? Everything we do is intensive and purposeful, and not as a waste of time. Those skills modules, you only had, what, the one for this one, I think, central access devices, because you've really not used these types of devices with vasoactive drugs before, okay? So they're there for a purpose to help you understand what type of IV therapy would your patient have. Module DF has a ton of skills in it, but they're all skills that go back to the basics and the basics are how we take care of people that all relate to module D and F, okay? So hemodynamics, know your normals, know what those numbers are going to mean to you, what could affect those numbers. Because then when you know what can affect those numbers, you're gonna know how to treat those numbers. Okay? I hope that you've already been studying, nibbling all along, right? That's the most effective way to learn, is to nibble. A little here, a little there, a little here. As you know, the path of the science of the brain, I told y'all last week, you have to have non-REM 4 and REM sleep in order for any concept to be stored. That's why studying all night long the night before is a waste of your time. Okay? So I know that somebody's got some questions and you're just being shy. Who's got a question? Go ahead. Good job,
We have
Juan.
an issue with, like, say we have mitral stenosis,
Okay,
and, it's, the blood is starting to back up to the atrium,
that's correct.
so we will see the peripheral, even though the even though it starts as left side, since it has to go to the pulmonary system, then to the arteries to the right side. As far as like test questions, even though eventually it will develop into right side heart failure, if we go with, it starts on that left.
Yeah, it does start with your left, and it's, you know, in that case, so let's say a patient presents with pulmonary edema, crackles, shortness of breath, orthopnea, you name it, okay? And the provider's like, could be left ventricular failure, could be mitral stenosis, and that's where the diagnostics come into effect. And we as nurses don't have to discern which one it is. By scope of practice, I don't have to diagnose, I have to know what I'm gonna do with this. So when the diagnosis is made, and we have mitral stenosis, now we understand why we would treat X, Y, Z, why this patient might need a valve replacement, why would I see pulmonary congestion, how we manage that, okay? So a preload reducer would be a really good thing for this patient, wouldn't it? Even though we're not getting to the ventricle, but we've got to manage this volume backing up to the lungs, okay? But yet I would also expect to see a reduction of cardiac output, wouldn't I? Because if all this volume is damming into the atrium and not going forward, I would expect to see, right? Okay? And yet, would a contractility drug help this patient? Yes or no? I see you thinking back there, Jay. Would a contractility drug help this patient? Yes or no? Right. Go ahead, Josh, say it.
We just really push more.
Really and truly, is it because we have a problem with our ventricle not contracting, that volume's backing up? It's really not.
It's the
That's
valve
right.
itself.
That's right. Okay. Told you I was gonna talk about positioning. Patients with orthopnea cannot tolerate the head of the bed being lower, and we know why, because water's heavier than air. And so when the patient is recumbent, water goes up. Okay? Same philosophy as a patient with a tube feeding, right? Why do we keep the head of the bed at 30 degrees for a tube feeding? To keep it from backing up the esophagus. Have you ever leaned over after you took a big old swig of coffee? Don't. I have. And I did it again this morning. I was like, okay, you know better. Oh, it's awful. And my coffee's hot. So I'm like that was just not brilliant. But because water is heavier than air, it's going to go that direction. So we keep the head of the bed at 30. Okay, so if I've got a patient with a balloon pump in, and they're ventilated, which they often are on the vent. If they're that sick, they often are intubated. How the heck am I gonna position the head of the bed at 30 and not bend the leg? How are we gonna do that? Say it, Jade. She's doing her arm thing over there. Come on, I know you know it, Pierce. How are we gonna position? Reverse Trendelenburg, that's exactly right. Because now I can get the head of the bed up without creating a kink in the leg, at the groin, right? Because I gotta have the head of the bed up, can't compromise that system. So, hemodynamics, what do they mean? What are they gonna tell me? How am I gonna treat them? The different disorders of the patient's heart. First, have to understand what happens normally. Then I can understand how abnormal affects cardiac output, pulmonary congestion. Then I can understand what treatments, and pharmacology is a lot of it, isn't it? looking at those drugs, what is my, so I have a drug that has a positive inotropic effect and a negative chronotropic effect. Go back to thinking about what did you have to assess before you okay, so the question's gonna be, we're just gonna throw it out there. You have to figure out what your priority vital sign is, and there can only be one. But yet this drug has two effects, positive inotrope, negative chronotrope. So then you go back to, what did I have to assess before I gave this drug? I had to assess heart rate. Therefore, my priority vital sign has to be, there you go, even though it also is going to affect blood pressure. Right? If you're given a drug that has a powerful vasodilatory effect, what is your priority vital sign? Blood pressure. Even though there may be some little random other effects of this drug that can do X, Y, Z. Okay? Because that's what we talk about when we talk about patient safety. That's what we're talking about. It's all about patient safety. But you see, if you understand what a vasodilator does, you don't have to memorize blood pressure is what you monitor, is it? If I understand that spatial relationship between size and pressure and volume, and I've made a bigger size that proportionally reduces the volume, therefore proportionally reduces the pressure, I get how it lowers blood pressure, right? Because I can imagine those vessels and the space in those vessels. Conversely, if I'm given a vasopressor, which tightens up that space, without affecting the volume, it indirectly affects volume, doesn't it? Doesn't directly, but indirectly. Okay, now I've squeezed that space together. Now, because of the proportion of the size, that volume creates a adequate pressure. Right? Okay. So, y'all don't be shy. Who's got a question? Name, you got a question back there? Ladies, y'all have a question? Where's your little signs at? I said, okay, I missed the little signs. Chloe, you got a question? Here we go. Kimberly, Sheena. Ladies, y'all have a question?
I guess when I be studying, sometimes I get, and maybe I shouldn't get too caught up in it, but like as far as like all the pressures, and I be trying to remember.
You know what, were you a visual learner, Kimberly, when you did your VARC? What I would suggest to you would be look at an image of the heart as you're doing that. Imagine what's happening if volume's going this way. Imagine how that's going to affect those pressures there. And what's going to happen when it gets too big here? How's that going to affect before that? Sometimes, and I know it's a lot. It is a lot. But when I think about just the basic premise of that, like central venous pressure, when I understand that CVP is measured in the right atrium, I also know, as Quan's doing with his hands, that that's where blood returns to from the body, correct? The only way for that volume to get into there is to come from the body, right? So then that would make sense to me that it's telling me about my overall circulating volume. So if that number is low, what about my circulating volume? What is it? Low. If it's high, my overall circulating volume is high. That's why that number is great in managing a patient with any type of volume deficit or hypervolemia. My renal failure patient, this is a great number. I can manage those volumes before they cause a problem. If this is a hypovolemic shock patient or hemorrhagic shock patient, then I would know that I've given enough IV fluids when that CVP is back to normal. We've given enough blood, not just by the H&H measurement, but when that volume is back to normal. Okay? CVP is really good to tell me about volume. Think about how that affects a patient with a very sick left ventricle. If you've got a high CVP, are we increasing the likelihood of pulmonary edema or decreasing the likelihood of pulmonary edema? Increasing it. Because if more volume enters, that's what's gonna happen. Your pulmonary artery wedge pressure was very specific to something. What was it specific to? That's right, it was very specific to the pulmonary capillary bed, meaning that it wasn't a space relationship anymore here. This was specific to the pulmonary capillary bed. If this number is high, you have volume in this pulmonary capillary bed. Whereas the PA pressure can give me a relationship with volume, but it also can be affected by what? Vasoconstrictors and dilators. And yet we use that number, why? Because of the complications associated with the wedge. We talked about SVR, cardiac output index, stroke volume, ejection fraction are all measuring volumes leaving the heart in different ways. Cardiac index is more specific based on body surface area, so it's a really great number because it tells me specifically what this patient's physiological needs are. We understand there's a relationship with heart rate and stroke volume to create cardiac output. We've got two mechanisms here that are going to compute cardiac output. If there's aberrations in either of those two values, that's going to affect cardiac output, correct? Think about the things that a patient needs to go home knowing. What do they need to go home knowing? They can't possibly monitor the effect of they're going to have monthly checks on their pacemakers, guys, via the telephone. It's really cool how they do this, but through the telephone they can actually, and now they got this Wi-Fi connectors too. You know, my husband's CPAP. My husband has structural airway issues. His BMI is normal. His airway issues are different. They can pull up his readings from his CPAP in the office. It's almost kind of scary. It's like, you know what I mean? It's like, I'm sure I like that, but I'm glad. Like you read what your consistent pressures are. You're like, but that thing's in our house. How are you? Anyway, but they can. Wi-Fi connection, and they can pull that thing up and read those. They monitor pacemaker checks monthly so that we don't have a battery going dead and nobody knows it, okay? Battery life is usually about 10 years. But I still need to teach my patient some complications that can be associated with that. How's that patient going to feel? When do they need to call? Correct, okay? So signs and symptoms of bradycardia, if that's what we're going to feel. What are those signs and symptoms of bradycardia? We talked about your DIG and your hypokalemia, right? Isn't it really important, this patient who's going home with DIG and a preload reducer, that I know what I need to teach them? Nobody's there monitoring their potassium level. Nobody's there monitoring their DIG level. And patients don't know that there's any correlation between some things and other things. They don't know those things actually go together, do they? So they're not going to voluntarily tell you, I've been nauseated lately, because they might not think that has anything to do with what they're experiencing. I just have a bug. But we have the education to know what questions to ask and what to teach them. So don't ignore these things, okay? What else? I know you've got questions. Pierce, you got questions?
Oh gosh. I mean, I would love just a very quick overview, just the what differences you're looking for us to know about cardiomyopathy.
Okay, so your dilated cardiomyopathy patient, structurally, what's wrong with their heart? It's very large. A rubber band that has been stretched so many times loses its ability to do what? Okay, so we have this really big heart with very poor function. So what are they at high risk for developing? Complication-wise. Think about volume and flow right now. Where is that volume going to go to?
Just
Poor perfusion in general and pulmonary edema. These are your pulmonary edema patients for sure. So very poor cardiac output signs and symptoms, pulmonary edema. So, that's right, crackles. So we need something to reduce preload, we need something to reduce afterload, and we probably need something to help that heart contract more forcefully. Don't we? Once we've given a preload reducer and an afterload reducer and a contractility agent, what should I see change in my patient's assessment findings? Reduce pulmonary edema. Okay, they should be able to lay back, in other words, less orthopnea. What else? What are you gonna say?
Increased cardiac output.
Increased cardiac output evidence. I should see evidence that volume is now going the way it's supposed to. The hypertrophic cardiomyopathy, we have severe remodeling of the myocardium, don't we? It is really thick. And if you look at the picture, you can only imagine it's a stiff ventricle on top of that. So I don't need it to be stiff during diastole, do I? I need it to relax for filling, and I need it to be forceful contraction. So this stiffness isn't helping us. So I have a very poor capacity for preload, don't I? Preload's definitely affected. All that remodeled myocardium puts them at high risk for what disorder? That's right, ventricular dysrhythmias. Think about what drug classification would be something I'd be like, I probably need to call before we give this. Okay? Again, that goes back to the fact that there is already a reduction of preload. Okay? Your restrictive hypertrophic cardiomyopathy, they're very rare. They're elderly people. Again, you have a stiff, rigid ventricle. You don't have that same degree of remodeling of the myocardium like you do with the hypertrophic, which is why you can actually see that they might actually give this patient a preload reducer, whereas your hypertrophic we would not. I wouldn't worry about that one as much, okay? So you got your dilated, that's your sick, weak, loose, floppy heart, often associated with chronic alcoholism, childbirth, chemotherapy, any agent that would cause those fibers to be destroyed. Okay, does that help a little bit, Pierce?
Yes, ma'am. Thank you.
Hypertrophic is often a young person when we discover it. It's usually not always discovered during exertional events, but often that's when they first, if they didn't already know there was a family history of this, that's ultimately they can have that, okay? You know, when we had if you have a young child die during surgery, like maybe they were having tonsillectomy, adenoidectomy, and they code on the table, that's not normal for it to be a cardiac arrest for a child. They're going to be investigating, do we have hypertrophic cardiomyopathy? Because there's just not that many, at that age in their life, unknown diagnoses at that point. You know, your tetralogy, your atrial septal defect, those things, they're going to be maybe at the beginning, but not long, okay? Sooner or later, we're going to know before that munchkin's walking, something's wrong. Whereas this can be kind of silent for a while, depending on the activity level of the child, etc. So when you have a 6-year-old code during a TNA, that's not normal. There's something, and it's most likely, if it's a cardiac arrest, it's most likely going to be something of this type of problem, okay? But that helped, Pierce? Okay, what else? Anybody else got a question? Jessica, you got a question? Tyler? I can't remember her name on there. Question? Nicole, okay, I'm getting there. Nicole, you got a question? Okay, guys? Winter? Jay? Brianna? Got a question or anything? Samantha, ladies on the back row? No? Kashina, go ahead. I mean, yeah, and I'll get yours too, Joe, I promise. Go ahead, Sheena.
Cardioselective drugs versus non.
Yeah, so there's a list of 6 beta blockers I gave you in the course. And this was a homework assignment for you, because I don't want you to there's gonna be an element of memory you're gonna have here, okay? But you're gonna have a, so cardioselective versus non-selective. What do I mean when I say this is a cardioselective beta blocker? What is it gonna do? It's only gonna work on the receptors that activate cardiovascular response. Whereas a non-selective beta blocker is gonna do what? It's really not picky. It might pick some pulmonary receptors, it might pick some cardiovascular receptors. Okay? Think of your cardioselective as a snob and your non-selective as not picky. Okay? I only like my green beans, what's the word? Not al dente. What's the word when they're crisp? That word, crisp. I only like my green beans crisp, steamed, whatever. And the non-selective is like, I don't even if they've been boiled for 3 days or whatever. Okay? Non-selective doesn't care where it binds. So therefore it can affect multiple different types of receptors. Cardioselective, snobby, only affects cardiac receptors. Now why is that important that I as a nurse understand which of those 6, and I'm giving you a very concise list, I'm not making you do all of them. I gave you the most 6 commonly prescribed ones.
Does it have any pulmonary problems like asthma?
That's good job, Christina. If you've got an asthmatic, okay, so again, this goes back to I have to know what happens under normal circumstances. Under normal sympathetic stimulation, if there was a, did I tell you about the snake at my back door? Oh, I did. I told my clinical group, didn't I? I didn't tell the rest of y'all? Okay. When my daughter was trying on my veil to wear with her dress to see if she wanted to wear my veil. We were walking across the living room, and I looked at my back door. Back of my house is mostly glass, and I looked, and I thought, did I just see that? And I looked again, and I told my daughter, I said, Audrey, look. There was about 6 foot, no exaggeration, because he went across the entire length of my porch, snake curled up on the jamb, like where the window came to the bottom, right there. It had zigzagged itself up and was looking at us, like we were doing something wrong. Like, what are y'all doing? Like, my house? And for a moment, what kicks in? Sympathetic stimulation, okay? Fight or flight. Like, I'm glad there's glass between me and you. Because he was pretty bold. He was like, Anyway, sympathetic stimulation, at that point, your pupils do what? Dilate. Why do they dilate? What do I need? A better visual field so I can see those awesome young bugles over here, okay? Those are bugles, aren't they? Yeah. Oh my gosh. Dr. Radney knows, don't buy them. Just don't buy them. Gosh, I know where they're at. Love them. Okay. Visual field so I can see what I'm going. Are there other snakes out there? That's what I'm looking for. Heart rate does what? Increases to help me get ready to do what?
Run.
Deal with it. You right. Run or figure out how am I going to get it. Okay. This is not the time for your bladder to say, can I pee? No, you take a chill. So we need bladder to chill out, right? What do I need my bronchial tree to do? To help me meet the physical, I need it to dilate. Okay, so again, if you don't know what goes on under normal processes, you cannot possibly discern abnormal or therefore know what to look for. So if I'm giving a non-selective beta blocker to a patient who has pulmonary disease, asthma, COPD, do I need that patient's airway to potentially be tightened? Because I understand what a beta blocker does. It's going to block what would normally occur. If a patient's under physiological stress, for instance, their oxygen saturation levels are dropping, isn't that going to start a sympathetic response? And isn't that going to then cause bronchial dilation, which is good. If I give them a beta blocker and they have one of those episodes, what's going to happen to their bronchial tree instead? Okay, now you see why you have to understand and know the difference. Because is it my job as a nurse to contact the provider, say, Dr. So-and-so, I see that you've ordered X for this patient. Just want to remind, make you aware the patient has a history of this. And do you want me to still give this? Now, if I receive the order that says, yeah, go ahead and do that, they're well controlled, whatever, do I have any other responsibilities before I give that drug? I want to document that before I give it. Quick little note, Right there, I can do it right there in little anecdotal notes. Order received to continue with current medication plan. Good. You have more education and training than I do. You have a strong reason for wanting the patient to continue to have this drug. I've done my job to make sure you're aware, and I've documented that I've made you aware. I've documented I've received the order to give it, and I'm gonna go give it now. And I'm good. Okay? If I document after the patient has a problem, is that gonna hold up in court? It's gonna look like you're doing CYB. I don't like cuss words. Do you know what I mean? Cover your behind. It's gonna raise some flags, like, hindsight 2020. So it only takes a second to document that, okay? Now, but a nurse had to know that before they even would question it, wouldn't they? Is it my responsibility to question those medications? Is it my responsibility to know those things? Yes, because if there's an outcome that's negative for the patient's part and you didn't do your job, you are fully responsible. Okay? Because it takes a team approach to take care of one person. Did that help? Who asked me about that? Was that you? Did that help? Okay, so look at that list, make sure you're clear on which ones are which, and why would we need to know that, okay? Jay, what was your question?
I was gonna ask, how many rhythm strips on the test?
Okay, I'm gonna focus predominantly on the pacemakers and potentially your atrial fibrillation strips. But predominantly on pacemakers, because you've been tested at 202 on rhythms, and 203 module E, we have a lot of rhythms on that test. So I'm not going to really, it won't be near as many as we will have on module E. On module E, you could see any of them. Matter of fact, you will see most of them. How many rhythms? The ones I'm really focusing on are your pacers. Because you haven't had pacemakers or atrial fib. You haven't had pacemakers up until this point. But they won't be tricky. They won't be tricky, Ricky. Okay? Straight up. What is it and what is your priority? What are your assessment findings? You know, I had a patient, or my cardiologist had pulled the transvenous temporary pacemaker. He had a bad inferior MI. I'll never forget him. CCU bed 4. I can tell you where I was. Some things are etched in your memory forever. And I had, oh my gosh, no sooner had he pulled that pacemaker, patient started having severe, long runs of complete heart block. And I mean, you talk about a long 12 hours. And I would run in his, about that time, his intrinsic rhythm pain, he goes, I'll never forget, as long as he looks at me and goes, did you turn out the lights? I'm like, oh God. No, I didn't turn out the lights. Y'all understand why he thought he turned out the lights? Because his lights went out. He really thought, dang, it got dark in here for a minute. Yeah. Call my cardiologist back and said, don't you want to put this thing back in? No, I think it's evolving. It should resolve. You want to sit here with me for 12 hours then? It's going to have a long shift. It did resolve. But it was a long shift. And it's true. Your brain is super, 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 super sensitive to perfusion, guys. Okay? Very sensitive. So what would you do? If your patient has a period of asystole, and your pacer's not working, what are you going to do? What would your priority action be? You've gone into a patient's room, they have no pulse. That's right. Regardless of the reason, I've got to restore perfusion, don't I? Okay, now if it's momentary and their pulse is picking back up, you go from there. Okay? What else? What are the questions we got about? Did that help, Jay?
Yes, ma'am.
Make sure I'm not keeping my levels. Okay, so this is what's going to happen. Today's Tuesday? Okay, I will look at emails up until about 3 o'clock today. Tomorrow I'm in clinical, so I typically don't look at emails. But I'll try to make a point of it. I hate to commit to that because things happen and I don't get to. I'll try to make a point to at least look at emails tomorrow afternoon.
but not after, let's say, 4. Okay, I'll try to make sure I look at emails, but after 4 o'clock tomorrow, we're at the test anyway, okay? I do have to start Module D after the test. I don't like to. That's the only thing about summers is because we have such short days. I don't like to start new content after a test. I really, really don't. But I'll give you a little bit of a break after the test, but we will have to start Module D, okay? Module D is short. It's very brief. If you've already watched the thing, if you haven't, that's okay. One module at a time. It's okay. I get it. I get it. But it is very brief, okay? Because it's really pretty much about vessel function. If you understand what's going on physiologically with the body, it really all makes sense, okay? I don't find it, students will either do very well or not well at all. Because they'll either get a conceptual understanding of what's going on with the shock patient or they don't. But much to my chagrin, we have to. Because Module F is going to take you a little bit more time, so Dr. Neal will start Module F on Tuesday. If I have to finish anything up on Tuesday, I will, but then she'll pick up Module F on Tuesday. Okay? So, I'll give you a break after the test, though. Don't forget, for testing, we maintain test security and an environment that's conducive for students' success. Meaning, you're not going to pop up in there at 1 minute till. You might as well just stay outside the door. I'm not going to let you take the test. Everybody else is in there. They've got their A game on. They're ready. They're logged in, and they're ready to take their test. And you're not going to come up here bumbling in there disrupting everybody. You need to be in your seat about 5 minutes till. Okay? Ready to take your test at 8. You'll need your digital or your hard copy ID. And that's pretty much it. Okay? I give you plenty of time to take the test. I give you 60 minutes to take a 50-item exam because there will be some things in there. You may have to do some computations. Drug cal is on every test. Okay, there's at least one, I would say. I don't know. I don't count anymore. But there's time built into that to give you that opportunity so that you can do that. Okay. Any questions about that? Don't. You know you're not going to get up during the test, so don't be drinking 5 gallons of coffee before you walk in. All right. And I want you to do well. I want you to, but it's up to you now, okay? It's up to you. Any other questions? My strong suggestion to you would be review normal processes first. What happens during sympathetic stimulation? What happens during normal cardiac function? Okay? I would strongly suggest you don't shortcut that for yourself. Okay? All right, guys. Y'all have a good day. My clinical group, I forgot to get your tools last week. Didn't think about it till I got home. Make sure you bring your ICU tools with you tomorrow so I can get those caught up, okay? I've given my group feedback. My clinical group, have y'all seen your feedback? I don't even know where y'all are at. Everybody got their feedback? It's on there. Okay, look and see. I've given you feedback. If something doesn't make sense, you can ask me about it tomorrow. I try to color code things so y'all can see what I'm talking about, okay?
It took me a minute to figure out